like a lot. So I think what we'll do is break it up into two. And today we'll talk about some theory and then just kind of some of the different things that we do as a service, Woodson and I, in terms of renal replacement therapy. So this is a picture of the pores and the filter, just to give you an idea of what it looks like up close. Okay, so has everybody seen podocytes before on the kidney? Okay, so this is in the glomerulus of the kidney. So the glomerulus is the sort of functional filtering little mechanism of the kidney. And so here we have the afferent. So the blood would come in this way. It would make a filtrate with these little cells that are called podocytes because they have feet. Podo meaning feet. And basically they form these little slits, and everything except plasma proteins can leak out through here. When plasma proteins leak out, like blood and that sort of thing, those are issues. And then the efferent, and then what is this part right here called? So this is the juxtaglomerular apparatus. Okay. All right. So this is what secretes renin. Okay, when you have renin, the renin-aldosterone system. This right here, this portion is what secretes renin. This is toward the end where the collecting ducts form. So this is your proximal convoluted tubule here, okay, going out. It wraps around and it goes through the loop of Henle, and then it comes back up here and it goes out to the collecting ducts, okay? So people with hypertension and diabetes, where they're uncontrolled, the part that gets damaged is the podocytes. So acute kidney injury. So we kind of know the clinical manifestations of this, but you'll see a lot of times we put the KDIGO stages, and that's more of a rifle criteria type of classification system for these patients. In acute kidney injury, and you can look this up online. Most of your patients that are going to be on CRT are going to be of stage 3, and really anybody that hits an acute kidney injury most commonly will have a chronic kidney disease going forward. Okay, that's why we're so crazy about trying to prevent those sort of things in the ICU. About 20 to 30% of patients in the ICU will develop an acute kidney injury. So in terms of urine analysis, pre-renal versus intrinsic, so these are sort of, there's a line between the two, but really it's a spectrum. So patients that have pre-renal disease can develop intrarenal failure if the pre-renal failure is not caught quick enough, okay? So in pre-renal failure, the function of the kidney is preserved. The problem is flow to the kidney. So when we hear pre-renal, a lot of times we think they need volume. That's not necessarily the case. Maybe they need inotropes. It's flow to the kidney. Okay, they could be hypovolemic, or they could be in cardiogenic shock. All of that would be a pre-renal state. In the pre-renal state, the kidney is able to maintain a osmolality. It's able to maintain a sodium. So the functional part of the kidney is maintained. Right? So if you have a low urine sodium, where sodium goes, water follows, right? So the kidney's trying to hang on to water, okay? In intrinsic failure, you see these are a lot higher, okay? You can't concentrate the urine, okay? You cannot maintain sodium, so you get a lot of sodium leakage, all right? Your FeNA, which is a ratio of plasma sodium to urine sodium, is high. And then urea, which is sort of another surrogate for sodium. What would be a situation where we would rather look at urea or a fractional excretion of urea instead of a urine sodium or a fractional excretion of sodium? What would be one situation where we would think about doing that? Well, so if we give somebody a loop diuretic and we want to try to figure out what renal failure they're in. Loop diuretics cause you to excrete a lot of sodium, right? And so that could skew your results if you're looking for that. Okay. So in terms of diuretic therapy, a lot of times you see us order urine urea, and we'll calculate a fractional excretion of urea instead, because urea is not changed by diuretic therapy. Okay. And then hyaline casts are sort of are not 100%, but they're sort of a hallmark of prerenal disease. Okay. So why does Dr. Woodson ask for all those abdominal pressures, right? Because of abdominal compartment syndrome that can be silent, right? And the problem with abdominal compartment syndrome, all this noise on the slide, is venous congestion. Okay, venous congestion causes a high afterload for the kidney, right? Because the kidney flows from, like most organs, from arterial to venous, and the filtering, the high afterload in the kidney causes basically a backup into the kidney, and you lose function that way. What's the normal abdominal pressure?
10 to 15.
Kind of around 10 to 12, yeah. And then a lot of times what we'll ask for is a bladder pressure with the associated mean at the time the bladder pressure was taken, so that we can subtract the map from the bladder pressure and you get the actual intra-abdominal pressure itself. Okay? All right. And you want that to be somewhere around 60. Okay? Another common thing that we see, especially in the CV ICU, is going to be rhabdo from, most of the time, from compartment syndrome of the lower extremities. It really can happen from a lot of things. And the hallmark of this is that there's the renal failure occurs because of congestion in the tubules themselves. Tubules clog up from debris. Myoglobin is a problem child with this, and then we get other hallmarks of renal failure, cellular injury, and then vasoconstriction because of myoglobin scavenging for nitric oxide. Okay. And these patients, how you try to treat it without CRT is alkalinizing the urine. Putting them on a bicarb drip and making sure their urine pH is close to 7. But most of the time they'll end up on CRT with some sort of chronic renal disease. Okay, this is important because based on the type of CRT modality you're on, these sort of molecules, the size of molecule is what's affected, okay? So a lot of times our patients, this is what we're trying to control, right? Their creatinine, their potassium, their sodium, all of these molecules are very small. You have your large sort of glucose, albumin, and then uric acid molecules. I'm sorry, albumin's up here, forgive me. And then inulin, uric acid, and then a lot of your electrolytes down there. When we talk about, we'll talk about in just a second, convection and diffusion. Diffusion is better for like your electrolytes, right? Remember that from way back in nursing school. And then convection is going to be better for these large molecular sized to middle molecular sized particles. Okay, so diffusion is kind of the sort of hallmark of what we do with CRT and dialysis itself. Basically what we're doing is we're driving solute based on a concentration gradient, okay? So we take a person and they have a potassium of 8, and we put them on a dialysate of a potassium of 4 or 2, and that concentration gradient, things passively happen to where the potassium diffuses down its concentration gradient. Things go from high to low, okay? There's a lot of, I'll let you guys, I'm not going to like read verbatim, I'll let you guys sort of go over this, but there's a very good website called Deranged Physiology, It's freaking awesome at critical care. It's really geared toward physicians going for their boards in critical care, and they have just, it's endless amounts of information on that, on a lot of this stuff, not just dialysis, but anything with critical care. Okay, so convection. So basically what we're doing with convection is we are driving fluid movement at a certain rate, and we are dragging solute behind it, okay? So we'll talk about the modes of CRRT here shortly where we use convection, but it's not very related to molecular size, it's more related to flow, okay? And filter, pore size, those sorts of things. So you can get urea, you can get things as big as albumin, small as sodium, urea, all those sorts of things can be managed with convection, and that doesn't necessarily require CBB-HDF every time, okay? And then we have ultrafiltration. So ultrafiltration is basically sort of, we could think of it as kind of a convection, but we're more so, it's a pressure-driven gradient, and more so, we kind of think of that, we kind of think of ultrafiltration as like a fluid movement, but a lot of times you'll hear it in conjunction with convection, okay? All right, so modalities, hemodialysis. There's two configurations for this. There is co-current hemodialysis, where the blood and the dialysate go in tandem with each other in the same direction within the filter. And then there's countercurrent. So we use countercurrent here, where the blood enters in one direction and the dialysate enters in the opposite direction. You get better clearance with countercurrent. There's benefits and there's advantages and disadvantages to both, but with countercurrent dialysate movement opposing the blood, the concentration gradients are kept high throughout the entire membrane, okay? And it's here, you can see here. Blood entering at the top here, the flow of dialysate entering at the top. You get sort of a down regulation in the amount of particle solute movement as you go lower in the filter. And then in countercurrent, where the flow and the blood and dialysate are in the opposite direction, you get sort of this maintenance, this maintained concentration gradient throughout the entire filter, okay? Better clearance. So hemofiltration, the main mechanism is ultrafiltration and convection, okay? We don't use dialysate, we use replacement fluid for that, and we can use it either pre-dilution or post-dilution, okay? So pre-dilution would be running it before the filter, and post-dilution would be running it after the filter, where it enters the deaeration chamber here, okay? And based on that, I don't know if you guys remember, based on what you have selected, these two little locking mechanisms right here, one is open and one is closed. And they open and shut based on what the setting is. So hemodiafiltration is both convective and diffusive, okay, in nature. All right. We have both a dialysate and a replacement. And we'll talk about PBP in a minute because we think of PBP, we think of citrate. And then a lot of times you'll see we have a bag of dialysate hanging in the PBP slot, and we'll talk about that in a second. So I haven't left that out, I promise. All right. So our schema for renal replacement therapy, we'll start with scuff, and basically we're talking about fluid removal. Okay. How we do this is we have a pump here that's driving the blood, and we have a pump here that's driving the effluent. Okay, the effluent pump is creating a negative suction, and the pump is creating a certain amount of force inside of the filter. And so we are driving fluid across the filter into the effluent to be removed. Okay. Advantages, it's good obviously for fluid removal, and we typically see that it says typically well tolerated. Most of these CRRT things are going to be well tolerated by patients. That's what they're meant for, is patients that are critically